Welcome to this healthcare equity presentation on how poverty changes healthcare outcomes. I'm glad you have joined us for this event. I am Bob Crayson, your host for this evening. First, a word from our sponsor.
These are the stories of Ohioans who have faced the issue of poor insurance coverage. Healthcare insurance costs are so expensive that it accounts for over 12% of our citizens' annual income. That's why Healthcare for All Ohioans is committed to helping people of Ohio to fix this problem by fighting for universal single-payer health coverage.
My name is Mindy Hedges. I'm a type 1 diabetic since the age of 5. When I started my company, I tried to get insurance for my employees. And I was told, first of all, that no one would cover us because I'm a type 1 diabetic. Eventually, we had an insurance company that had to cover us because they made a mistake in their quote. So even though they did cover us, they had us at the highest level of coverage cost, and each year would increase their coverage cost to their highest level, which put a great strain on a new company. We desperately need a new system in our country.
From business owners to physicians, your families, your neighbors, and to you. Everyone is having difficulties with the healthcare insurance system of Ohio and our nation.
Thank you. That was a video that was produced by Mindy Hedges a short time ago, and it's not finished yet, but I wanted you to see it as a good way to start this evening. Healthcare for All Ohioans, also known as SPAN Ohio, is a nonprofit group of all volunteers, Ohioans who seek healthcare for all people in Ohio. And we're also working for the nation through Medicare for All in the Congress and the Ohio Healthcare Act in the Ohio legislature. The legislation we support includes 100% of payment for all necessary healthcare issues. Our website, which you can reach either through Healthcare for All Ohioans or SPAN Ohio, has more information about who we are and what we're trying to do. I call your attention to an upcoming date, the SPAN Ohio State Conference on Saturday, April 27th at the Quest Center, which is in Polaris on the north side of Columbus. You're invited to attend. You can register through the state conference link on our website. I also invite you to become a member of our organization, also through a link on our website. When SPAN Ohio added an equity committee last year, it joined a growing list of organizations concerned about equity in healthcare treatment. Some people receive excellent medical care, others not so much because of financial barriers, race, nation of origin, culture, and where you happen to live. We're glad that you've joined us for this healthcare equity workshop on poverty and healthcare. We have a single speaker tonight, and then we'll have time for questions and answers session. Please write down your questions as the presentation takes place, either in the chat or for yourself on paper. When the Q&A period starts, please raise your hand electronically with the switch found in reactions, and I'll call on you. Nancy McCrickard will monitor questions in the chat. Our speaker tonight is Dr. Brad Cotton, who has spent a lifetime in medical care, no joke, lifetime. He's been in the trenches, He started by being an EMT in a tough neighborhood in Cleveland, and I can vouch for that tough neighborhood because I lived there. He eventually was able to gain access to the OSU Medical School, and he is now an emergency room doctor, but not too much longer. He's going to retire this year and then run as a candidate for a seat in the Ohio legislature, a representative in the 12th legislative district, which is in Pickaway and a small piece of Franklin County. Healthcare for all Ohioans is a central piece for his campaign. His long and compassionate biography is on his campaign website, which can be reached by typing in Brad Cotton. I encourage you to take a look. Please welcome Dr. Cotton.
Okay. Thank you, Bob. Can you all hear me okay?
Yes.
Okay. Unfortunately, with the laptop or the ears or whatever it is I've got, the only way I can hear you all is with these nice, sexy headphones on here. Hey, Bob, can I ask you, where did you live in Cleveland?
I worked in Holy Rosary Church, which is just east of the area in which you were EMT. It was on Murray Hill,
Okay.
Mayfield Road.
That was
I worked there for 2 years before I got transferred somewhere else.
That was what we call Medic 9's territory, which interestingly in 1985 was the busiest paramedic unit in the country. In fact, we used that in union negotiations to try to get an increase in pay and benefits, since we were the busiest medic unit in the entire country was in that area. I want to thank you for that introduction, and I must say that I'll be 70 in May, and as all of us, as we get older, look back on our lives at what we have done and so forth, what we are proud of and so forth. And I truly feel, even to use evangelical language, honored and even blessed to have been able to serve in such a meaningful job as a medic on the streets in Cleveland, emergency department tech, emergency department RN, and then eventually on to medical school. It is with the same commitment to ethics and the same commitment to honoring the role of a physician that I speak out and as active as I can be regarding Medicare for all. I'm advocating for patients for speaking to you here today. I'm advocating, as I have in my mind, all the ones I've seen that have suffered from not being able to get good care and had no choice but to come to the emergency department. We are, after all, the safety net. We are the only place regularly in the United States that takes all comers, and we treat you before we know who you are. We treat you before we know what your billing status is, before what is sometimes euphemistically called the billfold biopsy. And if you're a heroin addict and are sicker than the bank president, the heroin addict gets treated first. And that is the way we should be doing medicine, treating people in need without concern for what their financial status is. Unfortunately, in healthcare, care goes, in United States healthcare, the root of all problems in U.S. healthcare is the fact that it's a business. This is borne out in many ways. I urge you at some time to look at the Commonwealth Health International Studies, which looks at healthcare in Canada, the United States, Great Britain, Germany, France, Switzerland, Norway, Sweden, the Netherlands, Australia, New Zealand, total of 11 countries. And out of all the major countries in the world, the United States is the only country that treats healthcare as a business. Consequently, we spend twice as much as every other country, and we do it with much worse results. In fact, the United States is always rated, at the bottom in terms of equity, fairness, and access to care to people being able to afford their medicines. I will tell some stories here and a little bit of people who have been treated like throwaway parts by this healthcare system. My barber, who cuts my admittedly few hairs here, my server at Bob Evans, the guy who fixes my car, because if I had to fix my own car, I'd be walking. People that clean my hotel rooms, these are all great Ohioans, great Americans, and they deserve care. But they're treated like throwaway parts. Even under the Affordable Care Act, a lot of insurance plans are still just way too costly. The problem in the United States is not only people who are uninsured, but who are underinsured. We will talk about a patient of mine named Tim who was underinsured, meaning you think you have insurance until you try to use it. In fact, some of the selling points of conservatives are always trying to tell people, yeah, well, they like their private insurance. They like it until they have to try to use it. Same with Medicare Advantage, which is an attempt to privatize and actually destroy Medicare. Example where healthcare goes where the money is. A lot of us remember Mount Carmel West, that was on the near west side of town. All of a sudden they packed up and moved to Grove City. Now, was there suddenly any less need for medical care in the near west side of Columbus on the hilltop in these desperate neighborhoods of Columbus? No, there was a whole lot more money in Grove City. Okay. Also, what we see a lot of times is a lot of these ambulatory surgery centers, some of the more remunerative surgeries, orthopedic surgery and so forth. They are not doing their surgeries in bigger urban hospitals. They are moving to the suburban New Albany, for example, of these surgery centers, which often can charge an exorbitant rate because the physicians own. Most of the time, physicians are actually victims in this stuff, but there are some of them that are part of it. But they can actually charge a lot more because they own the facility. And what's happening is that is sucking the money out of the hospitals that we need, out of St. Anne's, out of Grant, out of downtown hospitals by these surgery centers. I remember, for example, when I was a medic in Cleveland, at that time, the Cleveland Clinic, we couldn't take EMS patients there. They didn't want anything to do with us common folks. But you can see the pyramid of the Cleveland Clinic lit up at night, and the helicopters flying in foreign oil sheiks to get their expensive cardiac bypass surgery. And some people would hold that up as an example. Well, we got what a great healthcare system we have. People come from all over the world to get care here. But me, blocks away, could not get my patients in need who had no way to get to the hospital except by calling EMS and had no other doctor that would see them other than the emergency department. There's no such thing as purely political question. I mean, all questions are moral questions. And I like that quote by Martin Luther King that we showed earlier. Particularly healthcare, is a moral issue. It is wrong. It is simply wrong that people suffer and get poor medical care because of their economic success. I mean, what exactly is success as a human being? We could debate that, but it certainly should not be correlated with your economic status. And in the emergency department, we see everybody that falls through the cracks, who has nowhere else to go. My professional association, the American College of Emergency Physicians, over the decades, I'm glad to see, has become more radical in responding to the fact that we work in this environment. 89% of emergency physicians report regularly seeing patients who suffered from lack of access to care. I submit that the 11% who don't report that are either so technical that they just don't realize that the patient is in front of them because they didn't have insurance, so they don't connect the dots. Either that or they work in incredibly affluent areas. The American College of Emergency Physicians has also recently really begun to have serious talk of unionization, not to protect us so much as physicians, but protect our patients from the rapaciousness of the healthcare system, protect our patients from surprise billing, as Nancy had mentioned earlier. I'll move on here. And again, you guys are getting the casual lack of sleep talk. I worked 3 12-hour night shifts in the last several days. And if any of you end up being emergency physicians or working all night, I give high recommendation to Death Wish coffee. This is my only product plug here. Twice the caffeine, supposedly, of every other kind of coffee. And it says it's for experienced coffee drinkers only. Gets me through the night shift anyway. I'll tell you, first of all, I have a number of patient stories here. There's a guy named Tim. This is not his real name. I've spoken about him a lot at healthcare rallies and at other sources. Tim was in his early 40s. He was married. His wife was a server at Bob Evans, and he had 2 teenage daughters. What's a little bit unusual about Tim medically is that he went into what we call atrial fibrillation, meaning he had a rapid, irregular heart rate, which I see Bob shaking his head, but I don't share patient. I blew it. I shared patient information here without permission. I take it that shaking your head was permission, but atrial fibrillation is kind of unusual in mid-40s, but still is a hazardous condition in that you can end up getting blood clots that form in your heart because it's not beating effectively, and those can be thrown up into your brain, causing a stroke. In Tim's case, this is what happened. In fact, I saw Tim twice. The first time is when he came to the emergency department when he was in atrial fibrillation. Tim, as I had mentioned, is one of those folks who is under-insured. He had an insurance plan that was provided by his employer. In fact, I'll stop there for a moment. So if we get healthcare for all Ohioans, it actually is better for business in Ohio, is better economically because we relieve them of the cost of having to provide health insurance for their companies. They'll spend about half as much money as they do now. As it is now, the employers try to get the cheapest insurance plan that they can. And it's always kind of curious, too, that one of the selling points for conservatives for our current system is they want patients to have choice. Patients don't get choice in our system. You get a choice of worse, or the worst plans that your employer may offer. If you get a Medicare Advantage plan, you lose your choice. The people that have the most choice, the most access to physicians are people on Medicare, on traditional Medicare. In fact, private insurance takes away your choice with narrow networks, surprise billing, limited drugs you can use. Anyway, so I saw Tim and I told him that generally what we do is I give him medication that slows the heart rate down. AFib commonly comes in a heart rate of 170 or so. We slow it down and we put them in the hospital so that they can be evaluated by the cardiologist, get echocardiograms. Sometimes they can get what's called an ablation, where they kind of using radio waves and electronics try to burn out those bad circuits in the heart. Tim was going to refuse being admitted, and I see this constantly all the time. People that need to be admitted that come into the hospital with chest pain, often with true evidence on EKG or blood work of having a myocardial infarction. They're having a heart attack. What are they worried about when they talk to me as a physician? Doc, I can't afford this. It's bad enough having a heart attack, and they're stressed knowing they can't afford it. Same with Tim. Tim was aware that his underinsurance plan had a $10,000 deductible. Okay. Having a lot of these insurance plans is like once you start to use it, you realize you're out on a frozen pond and the ice is a half-inch thick. It's 100 yards to the shore and you can hear the ice cracking. Tim heard that ice cracking around him. He had wanted to get braces for his teenage girls who needed them. His wife finally arrived, who worked at Bob Evans, and convinced him to be admitted to the hospital, which was the right thing medically for him to do. In fact, we sometimes talk about moral injury on the parts of physicians and providers when the system prevents us from doing the best job we can. Sometimes I feel pangs of guilt when I'm putting somebody like Tim in the hospital. I know it's going to cost him $10,000, that it needs to be done. Tim ultimately did decide to get admitted. He got his AFib under control, at least while he was in the hospital. And he did get sent home with a prescription for Eliquis. which is hugely expensive. A very brief aside, the drug companies claim that their drugs are so expensive because of research and development, which is in fact a bunch of hooey. Real, genuine medical advance for new drugs is actually done, paid for by you, the taxpayer. Brief example, the EpiPens, which are advised for asthmatics. Somebody let me know if I go on too long. I have not had any death wish coffee recently, so I got to sleep tonight, but if I'm going on too long, let me know. But there's about 1/10 of a cent worth of epinephrine in the EpiPens. What is different is the self-injector device, which was made for NASA, paid for by you and I. Instead, the daughter of what is that senator in West Virginia, Joe Manchin, his daughter is president of Mylar, I think is the pharmaceutical corporation. So once this has already been paid for and developed by you, the taxpayer, they get hold of the patent, and an EpiPen is now $600. We have a word for what we call this. It's extortion. This is why insulin is so hugely expensive, why cancer drugs are so hugely expensive. These cold-blooded people in pharmaceutical companies and the health insurance companies operate with all the ethics of Al Capone. They will charge whatever they can, and it's extortion that they will get this money. Well, Tim came back to the emergency department about 2 months after I saw him the first time. His wife came with him, and she was very thankful. Said, "Oh, great, we're glad we saw you again. You were so good with Tim the first time, managed to convince him to get treated. But now Tim cannot speak. He can make just a few flailing, incomprehensible noises. He can't move his right arm well. And it's too late for Tim to get some of these stroke-busting drugs that we've had. In other words, Tim has now had a stroke because he could not afford his Eliquis. Okay. Tim's teenage girls, the ones he was worried about getting braces for, came in to visit him. They're crying. His wife is crying. Even just to think, I tell the story because it's so vivid on my mind, it just makes me so sad and angry. Was there one of the Catholic saints said, if you're not angry in the cause of injustice, that's a sin itself. I come from a Quaker background. We're supposed to have peace at the center. Bob does, I know also. I have, if one is not angry at times, that's wrong. We need to be angry about this entire system and the way it functions. So Tim's life as a husband, as a breadwinner, he's a loss to Ohio. I'm sure he was an excellent auto mechanic. He is lost to Ohio. His taxes that he was paying are now lost to Ohio. He will now end up being a ward of the state, being on Medicaid. Tim's daughters that he wanted to get braces for, he can't even talk to them anymore. And this horror story and the United States healthcare system, if you truly look at how bad and how ugly it is like looking at the face of the medieval Medusa. To really understand how ugly this system is to be psychologically damaged yourself unless you're just, I don't know, I'm so tough, but unless you're able to somehow compartmentalize and deal with it or fight against it. I survive because I fight against how bad the system is. But Tim's horror has a name, has a cause, multiple causes. One of the causes is the fact that in the United States, we believe that healthcare is a business commodity to be sold to the highest bidder. It's similar to the fire department. If they showed up, your house is on fire, they want to know how much you can afford. Do you want, just the $10,000 deductible treatment to put your house out, or do you have better insurance? Depends on the care you get. There's thousands of these stories. Some of these here, I have to look at my notes, and some of this is based upon a talk. I think Bob was there that I testified before the Ohio legislature in December of 2018. Bobby, I saw as a teenage diabetic. I put Bobby in the intensive care unit several times for diabetic ketoacidosis. Diabetic ketoacidosis is a life threat each time. It can kill you. Bobby, excuse me, who often was not able to get his insulin. His mother had problems of her own, had to move often, couldn't keep up with all the Medicaid applications and so forth, and frequently went without insurance. My social worker could get Bobby a short-term case of insurance, but it would run out and he would be back in diabetic ketoacidosis. And who even still knows if Bobby is alive yet today? The news is always full of stories of diabetics who have died because they could not afford their insulin. Initially talking about Medicaid in itself, with the Affordable Care Act, it was allowed that states around the country could expand their eligibility for Medicare. A lot of the Republican red states, Texas is one of the worst states for healthcare in this country, chose not to, because even though the federal government would have covered the cost, it was a matter of us and them. We're not going to let these people tell us how to do healthcare. Interestingly, Texas didn't allow them to have any federal regulations in setting up their power grid system also, which is why it failed several years ago in a snowstorm. Because they weren't going to listen to no darn regulations and so forth. There's dramatic differences between the Republican Democrat way of looking at the world. Republicans believe we don't need referees. I know this is supposed to be non-political. I'm a candidate talking about healthcare. We need referees. I was born in Chicago, Al Capone's town, and Al Capone just hated government himself. He particularly hated the IRS. He hated regulations. People want to put regulations on his business. We need rules. We need regulations. The Cuyahoga River caught fire in 1967, was it? Because there was no regulations on pollution. And all this talk about freedom means freedom for the wealthiest and most unethical among us to do whatever they choose. And most unethical among us, I include the health insurance companies. Sue is another patient I saw. Sue was treated in a small Southern Ohio hospital, diagnosed with gallstones and discharged to follow up with a surgeon to get her gallbladder out. This is, like I said, we can't do everything in the emergency department. I'm the guy that sends you to the surgeon, to the cardiologist, to the dermatologist, to whatever specialist. The surgeon would not see Sue unless she had $200 up front to pay for the cost of visit. Sue comes to see me once in the tertiary care hospital in Columbus because now she has developed ascending cholangitis. She has a temp of 104. She's very septic. She's a life threat. And this happened because the surgeon wouldn't see her because she couldn't afford the copay. So she's now going to cost the state hundreds of thousands of dollars with an intensive care unit stay in emergency surgery, even if she survives. Sue, by the way, did not have insurance. She and her husband survived by having a home and office cleaning business for which they were often paid under the table. Sam is a suicidal teen who I know will wait in my emergency department up to a full week. This is when I was working in Columbus. It may have improved with Children's opening their psychiatric center, but still, we have psych patients sitting in the ER for a week waiting for a psych bed. They ended up becoming more acutely psychotic because, again, they couldn't afford their meds either. Pete, I saw with chest pain, one of so many, likely on his way to having a heart attack, refuses it because of cost. Ed had a broken arm. It's now bent because the orthopedic surgeon wouldn't follow up with him if he didn't have the cost to pay for the visit. Now, I've worked in some emergency departments where if you were a consultant, the orthopedist, the surgeon, you were required to treat these people. Some hospitals don't require that. You get booted out from the ER. All I do in the ER is if you're sick enough, you stay in the hospital. If you're not sick enough to stay in the hospital, you go home, and hopefully somebody else will follow up with you. Bill, I saw he's at risk of losing his job as a truck driver because of obstructive sleep apnea. To get treated for that, and I do want obstructive sleep apnea truck drivers off the road. They have fall asleep, crash into other vehicles. But he had no private health insurance, so he can't get the sleep test done to go ahead and therefore get his CPAP mask, which should keep him employed as a truck driver. What have we done for the state of Ohio when he can no longer be a truck driver, can't pay his taxes, can't contribute to society? Tina, I changed her name. She actually is one of the servers at Bob Evans that where my wife and I go for our hot breakfast date in the morning. Has I'm just seeing a note there from Indy Hedges. Emergency room care is a law. Yes, it's federal. We have to treat you in the emergency department, but I can't take out gallbladders in the ER. I can't take you to the cardiac cath lab in the ER. My job is to either admit you to the hospital or send you to the appropriate specialist. The trouble is the appropriate specialist won't necessarily see you if they don't like your insurance or Medicaid. I can't do everything in the emergency department. In fact, I would work no other place than a place that does see everybody. Tina, for example, is one of our server at Bob Evans. She's got nasty arthritis in her knee. You can see her hobbling around. Fortunately, I was able to get my knees done when it got to the point where I was walking into the patient's rooms, taking 6-inch steps, and patients are saying, "Doc, are you okay?" You know, I was able to get my knees replaced. I had good health insurance. By the way, I put that off for 10 years. So all this stuff about Canadian patients having to wait, I'll use strong terms. The ones that are complaining about waiting are a bunch of Karens who think that they are just better than everybody else and shouldn't have to wait and are able to afford to come to the United States. Anybody that needs emergency care in Canada gets it. I'm in communication. We go to conferences with emergency medicine colleagues from Canada. Emergency stuff happens. If you have to wait a little bit for an orthopedic surgery for your knee, that is a matter of absolutely zero consequence. There's a number of stories there I've presented to somewhat the moral argument, which to me is the reason why we need healthcare for everybody. I'm not much of an economist, but there are multiple economic studies done on this, one of which is on the Healthcare for All Ohioans website. Gerald Friedman did it, economic analysis of healthcare for all in Ohio. Overall, people save money. They will spend about half as much money as they do now on healthcare. Always trying to phrase this, and if I'm being filmed at some political event, how to phrase this so they won't make a soundbite out of it. Yes, that stake in the heart death word that Republicans like to use, taxes. Your taxes will go up slightly, but your taxes go up by about half of what you're currently paying for premiums, deductibles, copays. Your business will pay about half of what they're currently paying. It is an economic boom. Businesses will move to Ohio. One of the biggest problems is that we just have this idea unique to the United States, and I say it's pathologic. This idea that the Marlboro Man and self-reliance, and I don't have any responsibilities to anybody. I will sometimes say that Republicans, and it's a take line, I'm sure Brian Stewart will get hold of this and use it against me, but mouthy teens and Republicans are only concerned about their so-called rights. As adults and responsibilities, adults and Democrats know that we have responsibilities to each other as well. I have an interesting quote here, and I'm sort of slowly getting near the end here. Interesting quote, surprisingly, from Governor Kasich at the time, who did expand Medicaid in Ohio. And I read Kasich was speaking to his own fellow Republicans. He says, quote, "I respect the fact that you believe in small government. I do too. I also happen to know that you're a person of faith. Now, when you die and get to the meeting with St. Peter, he's probably not going to ask how much you did about keeping government small, but he is going to ask about what you did for the poor. Better have a good answer." It's amazing that came from a Republican governor. A good parallel to watch, if you want to watch a good movie. I've watched the Titanic so many times. I always have to have something to watch on the elliptical machine in the basement. The ship always sinks in the end, but who survived on the Titanic? It was the first class passengers. Who died? Second and third class, locked below decks to drown. This is the same way our health insurance system works. Yeah, we get good care if you have good insurance and you got money. Interesting. I just one more quote I want to read about the Commonwealth studies have showed that our healthcare system is one of the worst in the world. And if business and the market was the way to do things, we would have the best healthcare system in the world. Jonathan Ross wrote this very well about all the attempts to try to make this private insurance system work, which how can it ever work? The private insurer wants your money and then tries to spend as little of it as they can on your health care. I mean, that's a conflict of interest. Okay. Jonathan Ross says about all the attempts to try to make private insurance system work for us, quote, Band-Aids have been added to our for-profit system in attempts to expand access to care and control costs. We have tried HMOs, PPOs, ACOs, DRGs, bundled payments, high co-payments and deductibles, narrow provider networks, pre-existing condition exclusion, high-risk pools, pay for performance, and the holy grail for physicians' malpractice reform. These efforts did little to increase coverage or control costs. The Affordable Care Act did increase coverage, but added $100 billion annually to our already excessive costs and aggravated the extreme administrative waste. By the way, 31% of all our healthcare dollars are wasted on administration. Medicare runs on 3% of our unstable, complex healthcare financing system. Republicans continue to propose ways to cut poor citizens off from life-saving care through Medicaid work requirements and crippling the Affordable Care Act insurance market. Stopping there for a minute, one way thought to control healthcare costs is to give patients more skin in the game. In other words, make them spend more of their own money. What we're seeing is that patients like Tim and my other patients are in fact getting skinned alive. Back to Jonathan Ross's quote, such efforts have increased the number of Ohioans without insurance by 60,000 over the past year, and insurance premiums and drug costs have continued to skyrocket. It's clear this profit-driven healthcare system has failed.
Brad, I'm going to stop and interrupt you right there.
Okay.
I appreciate your message and your sensitivity to this issue of poverty and healthcare. Seems to me you're all over this. I'm going to have a question or two for Dr. Cotton, and then I'm going to open it up to everybody for questions because I think we need to have everybody's response and participation in this because it is something that affects us all. What is your read on the physicians in Ohio in terms of this proposal for health care for everyone? I suspect that there is a pecking order of some kind. Who is for it and who is against it?
Regarding Ohio specifically, Bob, I don't know that I can address that. I do know that nationally, the type of practice that one has as a physician determines one's attitude towards Medicare for all. And the closer one is to primary care, that is to actually have to sit down, look the patient in the eye and talk to them, the more likely they are to support Medicare for all. For example, the family practice physicians, the pediatricians, the emergency physicians, the psychiatrists, people who actually have to deal with people face to face, pretty significant support for Medicare for all. In fact, of all physicians nationwide, 56% support the idea of Medicare for all. The specialists that are a little bit less supportive of it are some of the ones who are making tons of money. Orthopedic physicians right now are the top paid physicians group nationally, and they're procedure-based specialty. In other words, they don't really deal with the patients long-term. They see them in the operating room in their sleep, replace a knee, and they're gone, getting tremendous remuneration for that. And I think they should be remunerated, but some of them see that their income could be threatened. Income of any particular physician group can be decided by public consent. We, the people, can decide how much is worth. One thing in Canada, for example, they did realize that they needed to increase the pay of orthopedists some, so because there was a wait time issue with knee replacements. But of emergency physicians, I think it's pretty close to around that 56-60% support Medicare for all, because we are the group that delivers the highest level of charity care of any group of physicians, because we see everybody that comes in the ER. Hope that answers what you were asking.
Okay. Nancy, do you have any questions in the chat that you would like to share with Dr. Cotton?
Well, I see there was a long strain about, or a thread about whether we could have clinics in schools that would serve everybody, serve all ages. It sounds like all the families. Eliza, do you want to speak to that?
I'm curious what you think of that idea, especially as we see hospitals closing and the whole issue of the sooner something is known about, the better. It seems to me like a logical thing to do, and that school buildings and school renovations frequently come up as both a Columbus and a local school district issue. Might be a clever way to really improve healthcare.
I don't know that I can personally address clinics and schools as regarding hospital closings. Again, what drives that is profit motive. This is why our rural hospitals are shutting down and closing, because there's
So, I mean, imagine if Columbus, if you don't mind my interrupting, imagine if Columbus required that any new schools constructed or renovated had to have a clinic that would serve all ages, not just high school students.
That's
It looks like Maryland has something to say too.
Okay. I speak to only what I can speak on based upon science and facts, and I can't really have any science or facts to comment on that one way or the other. I can say in terms of primary care, the United States has the lowest numbers of primary care docs per capita than any other country. People in Canada, people in the Netherlands have twice as many or a significant more number of primary care docs per capita than we do. Canadians see their primary care doctors twice as often as we do in the United States. And one of the things that's been neglected in this country is a good primary care system.
Mm-hmm. Would it even make sense to station paramedics, not so much at hospitals, but at schools, part-time?
Paramedics primarily are trained to treat emergency conditions, gunshots, heart attacks, and get them to the hospital.
Yeah, it's different.
Again, I'm not arguing against anything in schools. I just can't comment definitively on that, except to say in general that primary care in this country is neglected. And it's another part of the reason why everything is so expensive. We tend to be seen by a lot of specialists rather than seeing primary care docs.
I just want to say that the problem with clinics in schools is who's going to man the clinics, and there's right now one nurse is responsible for like multiple elementary and middle and high school. One nurse has to man all those different clinics. So I don't know what you how you want to man the clinics if you have them in schools. And at some point, I think even secretaries are handing out medications because there aren't enough nurses in the schools.
Yeah, it would take some creativity, but if people are doing medicine elsewhere anyways, I would move them over a little bit.
I'm going to jump in here just because I am a school nurse, or I'm a retired school nurse. As somebody wrote in there, location matters. So I worked in Cleveland, and currently the Metro Health sends out vans, and they are able to contact parents and work with students. They're not, and I know some cities, I think Cincinnati was looking into having clinics where family members could also go. The Metro Health vans don't do that at this time. But then, as somebody else was saying, in rural areas, you've got one school nurse for the whole city or the whole town. In Columbus, I believe there's a school nurse in every school, so they're treating the children. But so anyway, it varies from place to place. And but yeah, whatever model can be made to work could be good.
Linda Brown has her hand up. Linda?
I like that Eliza's question brings up the idea of what are other models or ideas that are out there, that we can't be, just tunnel focused on what we want. We have to be sensitive to what might be evolving. And with that in mind, I'd like to ask, since you're running for office, Brad, if you can comment much about the Healthy Benefits Plus card. I was behind a customer in Walmart today that used that card, and I've seen some others using it as well. And for those that aren't familiar with it, if somebody's been determined to have, I think the case of disability, but it may be other things too. It may be an income issue, but they're trying to provide wraparound services. You wouldn't necessarily get a food stamp card, but with your Healthy Benefits card, because you have a disability or health impairment, you can get over-the-counter products or other items that are supposed to help you with good health. If that's my understanding of it. I am not an expert, but it'd be part of the state legislator discussions. So I'd like to talk a little bit about that. Can you comment on it, Brad?
Who issues a Healthy Benefits card?
As far as I know, the ones I've seen people carrying in the stores are coming from like Advantage plans, the insurance company, the card that was issued. And that I'm glad you asked that question, because the card that I've seen, or cards, have been United Healthcare cards. And they're supposed to kind of act like a credit card or whatever the food stamp debit card, that's EBT cards, kind of like that. But they're being issued by the health insurance company. And the way it's been explained to me, and I don't know if this is true for all cards, but at least for some of them, if you don't spend your balance each month, it doesn't roll over. You can't accumulate it. So where does that money go? Because the reason I'm noticing them is so many people are having trouble with them. And the cashiers are complaining about how that they don't work. And people, they get in line with things that they think they're going to be able to purchase for their health, and then their cards don't work. And the thing is growing so big. When I was in CVS this week, I found here's 5 different catalogs for different insurance companies, depending on what insurance company you have, which products you're allowed to buy on your card. So now you've got to know.
Linda, I think you're getting into what insurance companies mean when you see in their advertising that contact us and we'll see if we can help you with the price. And this is the way they're helping you with the price. But it's really fits into their bailiwick of trying to gain extra income.
I think that we need to ask more elected officials who gets the money when the money on the card isn't working.
Yeah. Linda, I can't comment that anything that issues from a Medicare Advantage plan is perhaps more appropriately called Medicare Disadvantage plans, is designed to increase the profits of the Medicare Advantage plan and the people that are issuing those cards. This is how Medicare Advantage plans a lot of times suck people in, as they offer these benefits, silver seekers, this card, you can get some money for your groceries and so forth. However, it's when Medicare Advantage reintroduces, let me put it this way, if private insurance was good enough, we would have never had to introduce Medicare in 1965. Private insurance wasn't good enough. Medicare Advantage is a way of putting the camel's nose in the tent, and unfortunately has made it now halfway into the tent to reintroduce the private insurance into the Medicare system. People think they've got a good deal with Medicare Advantage plans until they actually get sick and have to start using them. And it's shown that people leave the Medicare Advantage plans in droves once they actually have to start seriously using them. And this is how they woo people in, as I see what Arlene Sheik is saying, with all these silver sneakers and all these various things that look good until you get sick and all of a sudden realize you hardly have insurance at all. They also have a lot of very narrow networks where you can only see certain docs, you can only see certain drugs. Part of what you touched on a little bit is getting into like pharmacy benefit managers too. That's another huge scam, where these are middlemen between the pharmacies and the insurers, and they skim a whole lot of money off the top. The entire system is designed to extract as much money all along the line as possible. And Joe Namath knew how to throw a football back in 1969, but he's got no business hawking these Medicare Advantage plans on TV. Yeah.
Kurt has his hand up. Kurt?
Yeah, can you hear me okay?
Yes.
Okay. So yeah, I'd like to chime in on the over-the-counter cards. Yes, Medicare Advantage is using that as a bell and whistle, so to speak, to sell you on the shiny thing, but Dr. Cotton is absolutely right. I have a sister who's 11 or 12 years older than I am, and she was on a Medicare Advantage plan because economically month to month it was good for her. But when she got seriously ill, they were second guessing all of her coverage, denying and delaying things to the point where she was getting sicker and sicker. So she had to get back to regular Medicare. For my situation, and I'm one of those fortunate retirees that has a union plan that is wraparound and does the gap policy. So I stayed in traditional Medicare, and now they're competing. Our pharmacy benefits managers are now competing with Medicare Advantage by offering their own over-the-counter card. But you have to be very careful if you use that card. If you don't shop for the correct thing, if it doesn't have their symbol on the price tag on the shelf, and you take it to the counter, it's not covered. So you've got a bunch of businesses, both over-the-counter medicine manufacturers and insurers, putting together a plan that they agree on. And who's left out? The patient. The patient's left out. You get this over-the-counter card, but if you don't use it, like you said, it doesn't accrue and it doesn't build up, that money stays with the insurance company because they've already gotten a certain amount of money on your head. They count you and they say, here's the money for that individual. And by the way, the insurance company can make you look sicker. They get to extract more money out of the payer. And that would be in Medicare's case, the federal government and the federal treasury. They risk adjust you based on the things that they say that you're treating you for. So
that's called upcoding.
There you go. They put you in a higher risk category. So anyway, that's my bit.
I am probably maybe the oldest person on this call. I'm 82, and I can remember when Medicare started. Medicare started because no insurance company wanted to insure people over 65. And that's when Medicare started as a public entity. It has been only recently that that the health insurance companies realize that they can make money now off of this public entity. And so that is what they have chosen to do. But originally Medicare was started because no insurance company wanted to cover these people over 65 at all.
And as Kurt alluded to, the Medicare Advantage plans do a huge amount of fraud, like you said, upcoding. In fact, to stop there, Tim Scott, who is currently senator from Florida, used to be governor of Florida, was president of Hospital Corporation of America, Columbia, who got hit with the biggest Medicare fraud thing ever. He was CEO at that time. These corporations, when they're found to be committing crimes like this, nothing's really going to change, that they just have to pay these little slap on the wrist fines. It should be that the CEOs and the board of executives goes to prison when these kind of things happen. Tim Scott should have been not right. There's different Scotts. There's the one from North Carolina also.
It's Rick Scott.
Yeah, Rick Scott should have gone to prison, not ended up being governor of Florida and then a senator because his company committed one of the largest cases of Medicare fraud ever.
Nancy, do you have any other questions in the chat?
Oh, I haven't followed the chat so much, but if anybody would like to raise their question, I think people are just making comments about Medicare. Raise
Any-
just your hand if you'd like to
Raise
ask.
your hand if you have any other questions. Yes, Linda.
I'm sorry, I have so many questions. One of the things I heard recently is that, and I'm so glad, Brad, that you are an ER doctor because you'll be perfect for this. Just this week, I heard it announced that there'll be a new reporting system going in place in the ER setting. You may have already seen it. Historically, if there was an overdose death, the hospital would be required to report it, right? If it was a death.
I can't speak to that. I'm a rubber meets the road guy. I take care of the overdose and so forth. What, some other people that are doing chart reviews and reporting later, I don't know that I can speak definitively to that. But I do know in general, overdoses are tracked. I mean, you can we find out when there's been a new crop of fentanyl or so forth, because overdoses will suddenly go up in an area.
And when they're tracked, are they tracked in association with an individual's health records, or are they tracked in the sense of community and zip code?
You mean, are they tracked? Is the individual's information released? That would be a violation of the health insurance and the HIPAA laws. And I don't see how anybody would possibly even think that they could report it in terms of individual identifiable data. It's aggregate data, deaths per zip code and so forth and so on.
Improving electronic medical records has been promoted as one of the ways to increase efficiencies and to do things in a better way. But if the electronic medical records can expand into other areas, and the Center for Medicare and Medicaid Services has suggested that it will, and then that was about a month ago that I heard them say that, and then Ohio said that yes, they're going to track not just deaths, which at that point, if you're dead, there's not, it's as much consequence for you as an individual, but that they would start reporting individuals. And so I just was a little concerned and wonder if part of the opposition we have from so many people about Medicare for all and say the use of electronic medical records is privacy related. And what can we, as an organization that wants to help people see the benefits of moving towards a Medicare for all system, how are we going to help the public recognize that privacy won't be violated, or that their individual rights won't be violated?
Ask people how much their privacy is violated on Medicare now. It's not, and I can't, I wonder about the sources of whoever's saying that your privacy is going to be violated, your individual data is going to be released. The penalties for hospitals or anybody releasing private information is so horrendous that one violation would shut a hospital down. So I wonder about the source of somebody of that argument. I'm not questioning you, but this social media is the world's biggest bathroom wall, allows everybody to write anything they want there, and that's Medicare does not violate anybody's privacy, and this we're just talking about an improved and expanded Medicare. But I can't see anybody releasing private medical information. You may remember when Damar Hamlin, that Buffalo Bills football player, suffered cardiac arrest on the field and was taken to Cincinnati. Something like upwards of 20 people got fired from their job at Cincinnati because they were trying to get into his record. I've had the penalties are huge for violating that private release of information.
Any other questions? Please raise your hand right now if you have a question or comment. Yes, Liza. Liza.
Do you happen to have any thoughts on recruiting people into various medical fields? Both because some areas are so few professionals per the population, and people who speak more different languages and cultures into our system.
There's a couple parts of that question. One, I saw it briefly go by because I can't read and talk at the same time on the chat room here. Part of the reason why we don't have enough primary care doctors in this country is people graduate from medical school with huge amounts of debt, and they realize that they're not going to make as much money in primary care, so they go into the more remunerative specialties. One solution to that is, I think, frankly, we should look at all of our students in Ohio. Myself, I'm a product of public schools. I went to a public university, Kent State and Cleveland State and Ohio State, and I went to residency, which was publicly supported all the ways. If we just looked at our people and our students as natural resources and didn't saddle them with huge debts and would take care of it, you would have less tendency of medical students wanting to go from primary care into I think you had commented some on underserved areas and rural areas and other places that are underserved. Once again, it's economics that drives that. Same with the inner city, where there's the technical word for that is payer mix. And one hospital I worked at where I made the most money for a while, I worked in Riverside's emergency department because they had a good payer mix there. Everybody had good insurance and good pay. And you work in some other ERs, the payer mix is not as good, and you can't get folks to go practice primary care there either because they just often can't survive on the amount of money that they can make. Medicare for All fixes this, and that every patient then becomes a paying patient. No such thing as bad debt, no such thing as charity care. In fact, depending which version of Medicare for All you use, one, it's either a very simplified billing process. You've got one person you bill Medicare, which is so much easier than billing, thousands, or not thousands, but hundreds of different insurance companies. Another version of Medicare for All just pays hospitals with a right out of the budget with the money that they need, so they don't even have to have billing clerks. A lot of these hospitals have one billing clerk per bed. And those people are all getting paid, and then the health insurer, they all have a bunch of clerks fighting back with these people. And this is where 31% of all healthcare dollars gets wasted in people trying to avoid paying bills or billing and so forth.
Nancy?
I think that has addressed most of what you asked. If it hasn't, let me know.
Nancy?
I just wanted to bring up Medicaid a little bit again, and one of the problems that I've seen in volunteering, in particular with homeless folks, when they come from another state, their Medicaid doesn't follow them. They have to sign out of Medicaid and then sign into it here. And then also Medicaid, I believe you have to re-sign up every year. And that's another big problem for our healthcare, that Medicare for All federally, across all the states would help deal with. But you also mentioned how, some of the states did not expand Medicaid. And I was just wondering how that works if somebody comes to Ohio and hasn't transferred theirs yet. I guess that falls into charity.
Register here.
Right. That falls into charity.
Tim, Bruce?
Oops.
Yeah, Brad, I'm 76. I'm on traditional Medicare. I have a Medigap policy, and I also have Part D drug coverage. And I have AFib too, like the other Tim that you were mentioning. So I'm on a blood thinner, which is an expensive medication. Last year I paid over $5,000 for all of that. For my healthcare, including some payments, that weren't covered by Medicare for some other healthcare that I had. So my question is, with Medicare for All, would my costs go down? How would Medicare for all differ from the traditional Medicare that I'm on right now?
Tim, that's a very good question. In fact, there's been a lot of internal discussion inside of our activist organization, Healthcare for All Ohioans, formerly known as the Single Payer Action Network, as to how do we brand ourselves? What words do we use? Been a lot of talk about this. Again, if I talk about Medicare, I hope I did during this context. I'm always try to be careful to say improved and expanded, compassionate, and cost-effective Medicare. You are correct. You can go bankrupt even on Medicare. Medicare still doesn't cover 20% what the bills. What we both our state of Ohio bill and the two federal bills for Medicare for all is first dollar coverage, takes care of drugs, no co-pays, no so forth. And believe it or not, this can all still be done, proven by 20 different economic studies, including one called the Mercatus, MERCATUS study, which was a right-wing think tank, may have been the Heritage Foundation, I'm not sure, that was designed to prove that Medicare for all wouldn't work and it was too expensive. And even they had to admit that nationwide it would save about $5 billion per year. Yeah, but we haven't been able to think of a good other quick, concise slogan other than Medicare for all, but it does leave us always having to explain that we're talking about improved, expanded Medicare, which is much better than current Medicare that we have. Does that answer what you're asking?
Yeah, I think so. I mean, I certainly believe, since I'm working also for Medicare for all, that my costs would go down. I'm for paying my fair share in taxes to provide Medicare for all for everyone. So I would prefer to pay in my taxes that way rather than out-of-pocket expenses that I have right now.
And studies nationally and in the state by Gerald Freeman, the economist, looked at our plan, showed that your taxes would go up by about 50%, not up 50% total, would go up by about 50% of what you are already paying in terms of deductibles, co-pays, and premiums. So in other words, you're just paying in taxes up front, but at about half the rate that you're already paying now. But the improved, expanded Medicare for all, its first dollar coverage, takes care of everybody. Let me just take this gratuitous example of throwing in one of my favorite quotes here by poet Wendell Berry. He says, quote, "Rats and roaches live by competition under the laws of supply and demand. It is the privilege of human beings to live under the laws of justice and mercy." And nobody should be paying $5,000 for their medical care up front. But, a lot of people can't afford that. U.S. life expectancy is lower than other countries. This is a big part of the reason why.
I think that I'm going to, on that note of that quote about the rats and the mice being competitive and we are supposed to be cooperative, I'm going to bring this to a close. Thank you, Dr. Cotton, for being our leader tonight, and appreciate your friendship and your compassion for the people that you treat. This program has been recorded, and it will be on the website very shortly, within a few days. Thanks for your attendance and your participation. And I want to encourage you to keep on the lookout for another of these equity programs on the website of SPAN Ohio. Thank you and good night.